pregnancy. In 2002, we have more than 1.5. It means that 3% of babies are twins. The reason, especially for RRT, for sure, but also because the age of pregnant women is more and more. We have more maternal risk, more consultation, more hospitalization, and we have to deliver in second or third level hospital. And we have more C-section. In France, we have about 50% of C-section instead of about 19% for singleton. And you have more perinatal morbidity and mortality, prematurity for sure, but this is the problem. The weight, the small for gestational age, it's 9 times more than in singleton. You see, it's 56.3% more than a singleton pregnancy. And also, there is not a huge difference between monochorionic and dichorionic. You see that in dichorionic, you have 20% of fetal growth restriction, at least to one baby. And in monochorionic, it's more, but it's not a lot more, it's 30%. You see, for example, for miscarriage, it's 10% of monochorionic, and in fetal growth restriction, it's 30% to 20% to dichorionic. So you see, the two problem is important if it's di or monochorionic. And we have, of this, we have a lot of maternal complication, diabetes, but also a high blood pressure and more morbidity and mortality to the mothers. So just to have a quick thing about twins, if you have dizygote, it means that you have 2 ovocytes and 2 spermatozoids. You have in 100% a di-di, it's been dichorionic, diamniotic. If you have 1 monozygote, it's mean one ovocyte and 1 spermatozoid, you have 66% of monodi, it's not di-di, monodi, and 30% of di-di. And you have 1% of mono-mono. There's an error, it's mono-di. When you have a monodi, it's always a monozygote. When you have monodi or mono-mono. But if you have di-di, in 95% it is a dizygote, and in 15% it's a monozygote. So all dizygote pregnancy are dichorial, but all mono or diamniotic are monozygote. So the difference between, you have to have the lambda sign in first trimester. This is very, very important. Lambda sign have been described by Roger Bessis, one of the past president of the French College. And you see here very quickly the difference between a di-di and a monodi. So let us speak about IUGR. The IUGR can be in the first trimester of a twin pregnancy. We can have difference between the CRL, between the 2 twins, or the biometry in second and third trimester, and we will use a lot of Doppler to understand what's happening. So the datation, if the difference in CRL is less than 10 millimeters, no problem for the gestational age to calculate the beginning of pregnancy. You take always the smaller one. This is a paper of Laurent Salomon in ultrasound last year. Now everybody is okay in ISIOC to take the smaller for the datation. But if it is more than 10 millimeters, it means that if fetus A is 65 and the fetus B is 42, for sure you have perhaps a chromosomal anomalies, and you have to do an invasive test. So we decided in France, and I think now it's accepted in whole the world, and when you have monochorionic or monoamniotic or diamniotic, you have to do ultrasound scan every 15 days. You have to do the estimation of fetal weight, the Doppler. You have to do the Doppler also on MCA and ductus venosus. You have to measure the cervix length every 13 days, even if it is mono or di. If it is di-di, a scan every month with the estimation of fetal weight of every twins for sure, the Doppler, MCA, ductus venosus, and the cervix also. So now let us take the monochorionic. You know that the principal problem of monochorionic is that we have a balanced transfusion between the two vascularization, and Yves have published it with a French title. He told the liaison dangereuse, like the film who have the same name. And the TTS is an unbalanced transfusion. I will not discuss this because I think that you'll have more information after. But just to tell you that the donor can have shock, brain damage, kidney, bowel, and intrauterofetal death, and the recipient can also have an intrauterofetal death. And when you see here a real TTS, you see the difference that sometimes there is IUGR, even if in the classification of Quintero, I haven't talked a lot of biometry, but we know everybody that if the biometry is important in this syndrome. Also, for sure, in this situation, I will not speak a lot. We have now the laser treatment. In France, we have 15 centers who do laser treatment for TTS syndrome. Also, we have also the TRAP, or the twin reversed arterial perfusion. It could be responsible of IUGR for the normal fetus. This is why we always decide that you have to treat. You can treat by laser, by cord ligation, by coagulation, or by US guide laser. This is, for example, a laser we have done by ultrasound. But so you have to treat, because if you don't treat, you usually have, unfortunately, this problem. Now, selective IUGR in monochorionic. We have discordance between the fetal weight between the two twins, and we speak about selective IUGR if you have more than 15% difference between the two twins, and especially if at least one of the twins is less than 10th percentile. I haven't speak about all curves because we have a lot of curves actually, but I think the future we will all use a prospective curves. It's mean like, for example, Intergross 21. I don't know if here in Greece you have begun to use it. Now we use it in France, and I think that this will be for all people, because you have more than 200 way to calculate the fetal weight. So this selective IUGR is concerned between 11 to 19% of at least one of the two twins in monochorionic diamniotic pregnancy. And for sure, the most important complication in this problem is the intrauterine fetal death. And the problem is, if when one of the twin die, we have 25 to 30% of intrauterine death for the other twin. This is a problem, but this is not the major problem. The major problem is even if he stay alive and he have neurologic damage in 20 or 30% of cases. This is why, for us, always if we have one intrauterine death, we have to do MRI in the third trimester to be sure there is no neurologic damage. So we think that it is unequal sharing of the placenta. When one of the two twins die, we have a lot of blood coming from one to other one, and we have an hypotension, an hypopression in the twin who is always alive, and this is what's responsible of the neurological damage. And sometimes we can see that there is a velamentous insertion of cord. So now I spoke about first trimester scan in France. When you have a first trimester scan and you have twin, you have to search about a velamentous insertion of cord. This is you are obliged to say, I've seen one placenta or two placenta if you have dichorionic, and I have seen the insertion of the cord. The insertion is normal, or it's a velamentous insertion of the cord, like this, for example. You see, or this one, or this one. So in selective IUGR, we have three groups of IUGR, And as I told you, we put them with a Doppler. We have the classification by Doppler. In type 1, we have always a positive umbilical diastole. It means that the resistance index is less than 1. In type 2, we have the index resistance 0 or more than 0. It means that 1, we have no diastolic, or we have a permanent reverse flow. In type 3, we have no diastolic index. It means an resistance index 1. But sometimes we have reverse flow, and sometimes we have positive diastole. I will show you now in images. So you see here, type 2, you have an index 0 diastole, no diastole, and the index of resistance index is 1. Here we have reverse flow, always reverse flow. It means that index of resistance is more than 1, 1.2, 1.3. So this is type 1, and this is type 2. This is not type 2, it's type 1. And this one is type 3, so you have sometimes normal, zero diastole, but sometimes you have a reverse, so this is type 3. In dichorionic, we can also have selective IUGR, and with the same thing that you have to have one of the two twins at least less than 10 percentile. This you have also to search about filamentous insertion of cord, because this is more frequent to have IUGR plus filamentous insertion of cord in di-di than in mono-di. And you have, when we have one who have IUGR, you have to thought that one of the two can have chromosomal anomalies, and you have to do amniocentesis. But because I've explained to you in the beginning that if they have the same sex, the same genital sex, so you have 15% of this situation that they have the same karyotype. So you have to do a double amniocentesis. You never do just one amniocentesis for the one who have the IGR, but double amniocentesis to be sure that there is not different expression of the pathology. Also, you have to discuss about fetal maternal infection, like Abdullah explained to you, CMV, parvovirus, etc. And always in your reflection, what to do, you have to privilege the normal twin. You have to not to think IUGR for just one twin. You have all of it means that if you have problem, you have to hesitate before 32 weeks. You have to say that the normal twin have to stay after 32 weeks. So usually we wait even if the twin have a huge IUGR, and sometimes we do selective termination if really it's very difficult to stay with this twin. So as always we discuss the low placenta insertion, you have also to see the abnormal funicular insertion like this one. You see it's a vasa previa. So think about this always, especially in twin pregnancy. You see here, you think that it is just a di-di with a normal, this is the membrane. In fact, look, it's not the membrane. It is a cord under the membrane. This is also a vasa previa. So you have to think about this. So, and just one word about monochorial monoamniotic. You have more than 50% of morbid mortality, especially if you wait after 34 weeks, because you have a lot of nodes. And this is why we decided in France that maximum and 33 weeks we have hospitalization, and we have to have a C-section before 34 weeks for all this twins pregnancy. So in conclusion, in first trimester, you have to do chorionicity, amnioticity, eventually zygocy, but this is not very important. You have to scan for chromosome anomalies, and now the NIPT in France is open to all twin pregnancy. We have to look, you explained Bernard this morning about vanishing twin, and the discordance till the beginning of first trimester between the two sex, and especially between the two CRL. In second and third trimester, if you haven't seen the chorionicity in first trimester, you have to explain the chorionicity in the second trimester. The fetal grow up, the fetal morphology, always to see the amniotic fluid quantity, the placenta and cord insertion every time, to do hemodynamic for the two twins with the MCA, and cervix measurement every time, every month. So just feel, because I am just to explain to you that you have our French society meeting in end of May. It's always the Thursday of Ascension, and if you want to come to see us, no problem. In the first day on Thursday, we do more 100 workshop with 100 patients, and then we have our plenary session on Friday and Saturday. So if you want to see Paris, don't hesitate to come to see us. Thank you very much.
Thank you. Thank you very much.